Good afternoon, everyone. Chairpersons, Dr. Bhavana Pant, please take the seat. I'll request Dr. Ashok Gupta, sir, to chair the session. With the permission of chair, can I start the presentation?
Please.
Before I actually start with the surgical anatomy of the temporal bone, there are certain things I want to share. This temporal bone is one of the most complicated areas in the human body. And adequate knowledge of the surgical anatomy forms the basis of good mastoid surgery. So anyone who is aspiring a good otologist has to dissect adequate number of bones. This adequate number can be 10 for someone and it may be 20 for the other person. So till the time he is comfortable with the three-dimensional anatomy, so he must do dissection, dissection, and dissection. That's my message. But the good point about the temporal bone is that the basic anatomy is constant. We know it, that's a dural plate, there is a sinus plate, there is a promontory, there is facial nerve, ossicles are there. Except for the cellularity of the mastoid process, the basic anatomy is constant. So with the constant practice, one can learn the anatomy of the temporal bone. And there is no substitute to dissection. These are the paired temporal bones that contributes to both the lateral and the skull base. And if we see from the cranial side, it has the anterior cranial fossa, middle cranial fossa, and the posterior cranial fossa. So temporal bone forms the part of middle cranial fossa and the posterior cranial fossa. So the temporal bone articulates with the various bone, the sphenoid, parietal, occipital, and zygomatic. The squamous portion is upwards, mastoid is backwards, tympanic is forward and downward, and the petrous is the medianward, styloid process is downwards. What does it mean by the squamous? The literal meaning of the squamous, it's a wing-like. Mastoid, it's breast-like. Tympanic, it's plate-like. Petrous is a rock-hard. And styloid is a angular process that is downwards. So in this temporal bone, I have tried to show the various parts, the squamous portion, mastoid portion, and the petrous is medianwards, tympanic portion, and the styloid process. And it's also showing the zygomatic process of the temporal bone. The squamous portion has two surfaces, the temporal surface and the cerebral surface. Because of the shortage of time, I will not be going to very much detail. The significance of the linear temporalis, that's very, very important. If we draw a line posterior to the zygomatic process over the mastoid, there is a line which is known as linear temporalis. What is the significance of this line? We have to limit our dissection lower to that. If we go above that line, we are likely to enter into the middle cranial fossa. And it also gives attachment to the temporalis muscle and temporalis fascia also. Although, if the constant practice, one can know where is the level of the, it can be low-lying dura, it can be normal position. So with the constant practice, one can know where is the position of the anterior lying sinus is there or low-lying dura is there. So we must understand the importance of linea temporalis. The zygomatic process. The zygomatic process is formed by two bones, the zygomatic arch. This is zygomatic process of the temporal bone, and temporal process of the zygomatic bone, they forms the zygomatic arch. The tympanic part, when we see, it's in the form of a plate which lies between the mandibular fossa and the external auditory canal. It forms the anterior wall, inferior wall, and lower part of the posterior canal wall. The petrous portion, I'll skip it. So the petrous, it has got anterior surface, posterior surface, and inferior surface, and it has got the base and apex. The apex is medially, and the base is united with the mastoid process. The apex lies in the angle between the basilar part of the occipital bone, posteromedially, and the greater wing of sphenoid anteromedially. Anterior surface, on the anterior surface, we can see a bulge that is known as the arcuate eminence in the tegment tympani. So that is the formed by the superior semicircular canal. The mastoid portion is the outer surface is roughened for the attachment of the various muscles, the occipital belly of occipital frontalis. The superior border articulates with the parietal bone and posterior border with the occipital bone. On the posterior part, we can find the mastoid foramen. On the inner surface of the mastoid portion, there is a deep curved groove for the sigmoid, that is known as sigmoid sulcus for the sigmoid sinus, and posteriorly the opening of the mastoid foramen. Just behind the external acoustic meatus, the mastoid part of the temporal bone shows a large downward projection called the mastoid tip. So it's like the nipple of breast. So when we see the dry temporal bone, it gives insertion to the sternocleidomastoid. On the medial side, mastoid notch is there for the attachment of the posterior belly of digastric. And medial to this, there is a groove for the occipital artery. We have a couple of bones over here, and anyone who wants to come and see the bones, they are most welcome after the session is over. Usually asked in the exam, the McEwen's triangle or Massivan triangle, this is a cribriform area. As I mark this triangle, the superiorly it's a linea temporalis, anteriorly it is the posterior-superior portion of the bony meatus, and posteriorly it is bounded by the tangent to the external aortic canal. So temporal bone surgery is based upon the landmarks. We must not destroy the landmarks till the time we find another set of landmarks at a deeper level. And we must utilize the bone maximally, and it can take about a week to dissect the complete temporal bone. One should not be in a hurry to finish everything in a couple of hours. The instruments that are required: good quality microscope, micromotor, blade with handle, periosteal elevator, fair elevator, tooth forceps, Caesar, TM elevator, sickle knife, and all those instruments that we require for the ear surgery. So we must plan how to utilize the bone. We can do the various procedures. Starting from the elevation of the tympanometal flap, we can practice for the grommet insertion. We can do the various, we can do the cortical mastoidectomy, transmastoid tympanotomies. identification of the semicircular canal, identification of endolymphatic sap, canalplasty, episiotomy, facial nerve decompression, labyrinthectomy, identification of internal acoustic canal and its contents, and then lastly we can do the canal wall down procedure. We must have assortment of cutting and diamond burrs. So most of the dissection is done by the cutting bars. Many of the, in the exam, they ask, how do you decide the size of the burr? So we should try to use the biggest size of the burr for a given area. Suppose the area is only 3 millimeter, how can you use the 4 millimeter burr? For a given area, you should try to use the biggest size of burr. And diamond burr is used near the delicate structures. Burr should be cleaned with a metal brush. Don't leave the burr in water or saline to avoid rusting. Formalin tablets should never be used for the sterilization. So various landmarks that we can see, the linear temporalis, spine of Henle, external canal, base of zygoma, glenoid fossa, mastoid tip. This specimen must also be examined for the presence of dura or the cranial nerves and other vessels also. And usually asked in the exam is which side of the bone temporal bone is. You should be able to identify the side of the bone. And when we do the dissection, we should always keep the bone in surgical view position. That means external aortic canal is anterior, mastoid tip is inferior, linear temporal is on the superior side. So when we do the basic mastectomy, it's also known as cortical mastectomy, Short's mastectomy, complete mastectomy. There are various names given to this. When we start the dissection, there are two ways. One, first cut, we can make it along the linear temporalis. The another cut we can make from linear temporalis going up to the tip of the mastoid process. There is another way. We can make a triangle giving first cut at the linear temporalis, second cut parallel to the external aortic canal, and third cut along the posterior border of the mastoid process. This is known as triangle of attack. This is a term which was coined by Dr. Mario Sana, and this is known as triangle of attack. So, McEwen's triangle and the triangle of attack, there are two different terms. Why this is known as triangle of attack? Because just underneath here, there is nothing important is there, and you can quickly do the dissection. Of course, you have to keep in mind the position of the dura, position of the sinus, and you may not enter into the external aortic canal. So, we should always do the wide exposure. We should do the wide removal of the cortex. Never be in a hurry to look for the mastoid antrum. So it's important to expose the middle fossa dura plate, best possible access to into the antrum. Sometimes we are not able to reach to the mastoid antrum. The other way is you should follow the dural plate. If you go anteriorly and medially, automatically you will reach to the mastoid antrum. Posteriorly, the sigmoid sinus plate is there, is a smooth plate, and we can keep on doing the dissection till the time we find cells. The dural plate and the sinus plates, they are plate-like structure without any cells. So in this picture, the sigmoid sinus has been exposed. It was injected bone. The mastoid antrum, very oftenly it is asked in the exam from the MS students, how do you identify the mastoid antrum? Sometimes we find a corner septum and we are much more superficial and we are not able to decide whether it's a mastoid antrum or not. There are a couple of things which you should keep in mind. One thing is you should keep the level of annulus in your view. Mastoid antrum has to be deeper to that. It cannot be lateral to that. Secondly, when you reach to the mastoid antrum, you will find the bulge for the lateral sensory canal. Movement of the drilling should always be in the direction of the important structure. You should drill parallel to that, never perpendicular to the important structures. So this is the complete cortical mastoidectomy. In this, you see the thin dural and sinus plates, open sinodural angle, digastric ridge. The posterior artery canal is very thin. We should have it thin so that you are able to see the shadow of the instrument from the other side. We can see the mastoid antrum, and the lateral sensory canal is also visible. About the epitympanotomies, I'll explain about the posterior tympanotomy. This is also known as facial recess. The boundaries of facial recess are posteriorly, it's the vertical portion of the facial nerve, anteriorly, it's chorda tympani, and superiorly, it's the fossa incudis, or incus buttress also sometimes you call it, because we leave a very small shelf of bone. So in this, we can see the various structures. We can see the IS joint. We can see the promontory, we can see the handle of malleus, and sometimes we are able to see the horizontal portion of the facial nerve as well, and the processus cochleariformis also. Again, these are the various things. Sometimes, if we do the extended posterior tympanotomy, we are able to see the opening of the eustachian tube as well. And these are the pictures when I started doing the dissection. I used to take the pictures of my own bones, and then I made this presentation. These are the very old pictures. So I will show you. When you do the canal wall down, it should be well saucerized cavity, round in appearance. The posterior canal wall is lowered to the level of the facial canal. The floor of external canal and the mastoid cavity should be at the same level. There should not be any obvious cell left in the mastoid cavity. All the accessible air cells should be removed. Because if you don't remove the cells and the mucosa is there and you have obliterated, it will keep on secreting. So all the accessible air cells should be removed. So these are the few badly dissected bones. In this we find high facial ridge, inadequate removal of the mastoid cells, there is a bony overhang, inadequate opening of the sinodural angle, and the canalplasty is also inadequate. So we'll be removing one by one. The perisinus cells have been removed and the posterior edge of the cavity has been saucerized, and we can easily see the sigmoid sinus plate. In the next, the tegment cells have been removed and the tegment border has been saucerized. Now the sinodural angle has been opened up. Facial ridge is also lowered. The anterior attic recess has been widely open because this is one of the areas where we are likely to leave behind the disease in the anterior attic region. For the facial nerve decompression, first of all, we must know about the position of the facial nerve. So in this, posterior tympanotomy has been done, and it's a vertical portion of the facial nerve is being shown. In this bone, we can see almost each and everything. We can see this is processus cochleariformis. This is the tympanic segment. This is pyramid, stapedial tendon, head of stapes, and the vertical portion of the facial nerve, horizontal sensory canal. And anteriorly, in other bones I'll show you, we can see the carotid artery also and jugular bulb also, which lies medial to the vertical portion of the facial nerve. So again, in this bone, all the three sensory canals are shown, the lateral, posterior, and the superior. So these are the two bones. In one, it is canal wall up, another one is canal wall down, and we can see each and every structure in both. We can see the superior canal, lateral canal, posterior canal, and another canal wall down has been done. We can see all the three ossicles. We can see the chorda tympani and portion of the tympanic membrane anteriorly, sigmoid sinus is posteriorly, and superiorly there is a dural plate. So I think I will not go into much of details of labyrinthectomy and other things. And if people want it, this presentation is for about an hour or so. If you people want, I can have a Zoom meeting with all of you and present this presentation to all of you. Any question would be most welcome from all of you. So all the three canals have been dissected: superior segmental canal, lateral canal, and the posterior canal. And we can also see the crus commune. This is superior and this is the posterior. And we can see each structure. This is processus cochleariformis, tympanic segment of the facial nerve, pyramid, head of stapes, round window, promontory, eustachian tube opening, and this is the jugular bulb. This is another bone. Complete labyrinthectomy has been done. So in this, I have tried to show the contents of the internal auditory canal. These are the, we can see in this superior vestibular nerve, inferior vestibular nerve, facial nerve, and the cochlear nerve as well. So I'll take just a couple of minutes more. So that I had shown from outside in technique. Now this is the inside out technique. We can see the tympanic membrane. We can see the tympanomastoid suture line. And the first step is, after elevating the tympanometal flap, we should widen the external aortic canal. Again, we can see the tympanic membrane. And this flap has been elevated. We can see the various ossicles, chorda tympani, tympanic membrane. So we are going posteriorly. Again, all the three ossicles are there. We are able to see the chorda tympani also. We can see the malleus. You can see the malleus, incus, stapes, even the crura are seen, round window, pyramid, stapedial tendon, and other structures. So this is another bone. In this, I had removed the incus, and we can see the malleus anteriorly. we can see the malleus anteriorly, and this is the stapes posteriorly. This pyramid, and this is the lateral sensu canal. In this also, we can see almost each and every structure: eustachian tube opening, round window, promontory, pyramid, head of stapes, stapedial tendon, processus cochleariformis, lateral sensory canal, sinus plate, jugular bulb. In this, I just wanted to show anteriorly, you can see the jugular bulb over here. It is bisected by the vertical portion of the facial nerve, and anteriorly, you can see the carotid artery as well. So this picture is showing complete picture of the facial nerve, vertical portion, vertical portion, this is tympanic segment, labyrinthine segment, and the internal auditory canal segment. I just reflected the facial nerve anteriorly, and we can see all the parts of the facial nerve. This is vertical portion, second genu, tympanic segment, first genu, labyrinthine segment, and the internal auditory meatal portion as well. These are the various bones which were dissected by me. Again, these are the complications. I took some pictures from the other persons also, just to show what are the complications. We can injure the sigmoid sinus, we can injure the dural plate, we can injure the facial nerve. So success is 1% inspiration and 99% perspiration. Thank you so very much.
Thank you, Dr. Vikas. A beautiful presentation. I think it will be an eye-opener for all the residents. Thank you.